show.
Thanks.
Want to introduce yourself and tell us what you do?
Yeah, my name's Josh Goodwin. I'm the physician here at Regenexx Las Vegas. So basically at this clinic, we treat orthopedic problems non-surgically with injection-based treatments. The main focus is utilizing different healing factors from the patient's own body to try to improve pain from an orthopedic condition. So that could be like degeneration, arthritis, overuse injuries, tears of tissues like rotator cuff or other tendons, ligament issues, spine conditions with bulging or herniated discs, sciatica type problems, spine arthritis, but all with injection-based treatments.
And what made you get into that?
Well, I think so in fellowship. So I did a sports medicine fellowship and an interventional spine fellowship. And one of the at the clinic I was working at, they were doing a research study looking at using people's own stem cells from bone marrow for low back pain. And so there was a randomized study, and so I got involved with performing that research. Obviously, at the same time, we were doing more traditional treatments with, steroid-based injections, burning nerves to try to help kind of blunt pain responses. And then obviously for people that didn't respond to that, send them to the surgeon. I just remember seeing patients come back, and we used to keep like a running list of, the date, the type of injection we did, and the response. And what you saw in patients with, cortisone or these different types of treatments is these lists just got like bigger and bigger and bigger. And it's like 2 months of improvement, 2 weeks of improvement, no improvement. And then you're just going down and like just doing more and more and more injections. And it seemed like, were we really helping people? So that, along with helping with performing the study using people's own cells, and then learning actually about Regenexx, who I eventually joined. They were publishing a lot of research. There were some big conferences about regenerative medicine and research coming out on, PRP and these different things to help with orthopedic problems. And it just made more sense to me to be able to potentially help improve the tissue, strengthen it, and and maybe have more long-term improvement as opposed to cortisone injections, which we know, and more in research is coming out about the potential negative aspects of those types of injections in regards to toxicity to cells. They're not necessarily healthy to your cartilage or your tendons or whatever's being injected into. Their effect on like blood sugar, bone health and strength, so that kind of stuff. So, and just more short-term improvement. So, seeing if there was something a little healthier, longer lasting, has the chance to improve the tissue, just made sense to me that that should be kind of a focus on other options to treat orthopedic problems. So it just made sense. So then I looked into Regenexx, and then in 2015 joined Regenexx and have been doing this kind of treatment since then.
Did you always want to be an MD? Is that how you started your career path?
No, going through college, I wanted to do physical therapy, so I always had like a focus on, like physical therapy or helping patients with, get back to function. I played sports in high school. I ruptured my Achilles tendon, so I had some injuries, and I just wanted to kind of be involved with kind of athletes and people getting back to, recovering from those kind of things. So I did a lot of kind of volunteer work with physical therapy, working in hospitals and outpatient clinics. And that was kind of my main focus. And then I had a professor I worked with that I did some research with in like exercise physiology. And at that time, he just kind of planted the seed, maybe, why don't you think about medical school? And I just did a little research at the time about different types of fields in medicine. And and so I learned about physical medicine and rehabilitation, which, I could be kind of involved with similar things that I was looking at previous, which is physical therapy, but maybe there was kind of a wider spectrum of things I can get involved with. So that led me to apply to medical school, and then fortunately I got accepted, and then went down that path of trying to figure out what type of doctor I wanted to be, which kind of changed a little bit as the years went on. Went in thinking I wanted to do physical medicine and rehabilitation, which I ultimately did, but I jumped, around with anesthesiology, orthopedic surgery, internal medicine, because as you do things, you're like, oh, I like this component or that component, but ultimately ended up where I began and why I went into medical school.
Very cool. I'm still trying to decide what I want to be when I grow up.
Yeah.
So for our listeners, could you describe the difference between, or what PRP is, and then that versus stem cells?
Yeah, so PRP stands for platelet-rich plasma. So it's essentially when we take blood, and within your blood you have different types of cells, right? You have red blood cells, white blood cells, and you have platelets. Platelets have many functions in the body, some of which is just for clotting. Obviously, we've cut ourselves and you stop bleeding, and so platelets are involved with helping control bleeding. But in that process, they also contain growth factors that help initiate and stimulate a healing response, a repair response. So I kind of call them the first responders to injury. And so they're there to kind of help control bleeding, but in that process, they'll also initiate a localized healing response through the release of growth factors. Growth factors help stimulate different parts of healing. So there's some growth factors that improve blood supply, that directly stimulate tissue for repair, help improve collagen production, recruit and activate stem cells into the environment, which we can talk about. And so they're just that activation cell that kind of gets things going. And so you can use those properties by extracting platelets and concentrating them, which is why you could call it platelet-rich plasma. So you're kind of elevating the number of cells per unit volume compared to your baseline, so that there's like a more robust signal in the area that you're trying to treat. But you can use those properties of healing activation, trying to improve the stimulation of collagen production, and maybe improvements in vascular supply to the area. And you can do that just via needle-based, injection-based treatment options. And other things within PRP, so there's like the plasma portion. There's also, when you're kind of concentrating, isolating those cells, there's growth factors, or these things called cytokines, that help kind of maintain the balance of controlling inflammation. And so there's some anti-inflammatory proteins that help reduce inflammatory signals that are sometimes present in like arthritic conditions or overuse type situations where you have like a tendinitis or something where there's inflammation. So it can help in that sense. So PRP is more stimulating to the tissue, has some anti-inflammatory properties, as opposed to, say, a stem cell procedure, which we're specifically talking about a stem cell called mesenchymal stem cells. You also have hematopoietic stem cells, which are found in your bone marrow, that help produce all of your blood cells, which they might have some properties to use as well. But for orthopedic problems, we're talking about mesenchymal stem cells, which you can find throughout your body. People have isolated it from fat tissue. You can find them within your joints. We tend to isolate them from the bone marrow, where they can be found in high concentrations, free-floating, under the bone, around blood vessels, called pericytes. But those cells are also involved with maintaining tissue and kind of organizing a healing response. So as opposed to platelets only being activating and stimulating to the tissue, stem cells can help kind of act like a contractor at a construction site, so they can kind of help direct repair. They can communicate with the local tissue by release of different protein material that help improve the health of the injured cell. And obviously a unique characteristic of stem cells is their ability to transform into different types of cells depending on the environment they're in. So when you check properties of mesenchymal stem cells in the lab and look at their different kind of potential, they can, based on the environment, can transform into a bone cell or a cartilage cell or a muscle cell based on the environment. So they have that additional characteristic and potential for being able to become incorporated into that tissue, which for situations that there's maybe more tissue loss, stem cells may be a little more effective, where PRP tends to be used in more mild to moderate conditions, like where you have some thinning of the cartilage but not necessarily bone on bone, or you have very tiny tears or inflamed tissues. Once the injuries get bigger, then PRP tends to be less successful. And so you might use stem cells in these other types of conditions that maybe are a little more severe. But they're both involved with healing naturally, right? And they both kind of work together. So those growth factors can kind of help recruit and activate localized stem cells in an environment. In fact, if you're growing stem cells in the lab outside the body, to feed them and kind of keep them functional and growing, you can just put them in an environment of platelets and growth factors and they can grow. And so that's without any additional like nutrition support. It's just that, and that can help keep them functional and expanding. When you're just trying to look at growth rates and things, you can just use platelets and growth factors. So there's like kind of the synergistic kind of relationship that these two different cell types have within our bodies, and they work together.
Are there scenarios where you would use both PRP and stem cells, like a combination, or is it mostly separate, like you would just use?
No, yeah, I think when we do bone marrow procedures, we do utilize PRP as well with it because of what I just mentioned. As far as our process, if we do, say, a bone marrow-derived stem cell treatment, following that, we inject PRP as well. So it's part of that process. Mm-hmm. And obviously the rationale is just how they work, and how stimulating platelet growth factors are for activation of those cells in regards to healing, or at least in regards to how these cells grow in the lab, and checking those characteristics, which I think likely mimic what happens in the body, right? So.
And does everybody get the same amount or concentration?
No, so that depends on a lot of different factors. So in regards to PRP concentration, you have to look at a lot of different things. So the age of the patient, right? So there's studies that have looked at kind of growth rates in regards to age. So looking at, say, tendon cells and at young patients versus older patients, and what's the relationship to how well these tissues grow in regards to PRP concentration. And so younger patients don't tend to need as high of a concentration. So you don't need to go as high in younger patients, where as people get older, to get the same type of stimulation effect, you have to go higher on the dose. And so being able to customize the concentration based on the patient's age, the severity of the problem, and then the tissue type. So are you treating soft tissue like tendons, muscles, ligaments, as opposed to a joint, a disc, those kind of things? Each one of these structures may respond better to a different type of concentration. And there's also different types of PRP. There's what's defined as leukocyte rich, that has maybe a little more white blood cell component to it, versus leukocyte poor, which is reduced in those white blood cells. And there might be different situations that you use these different types of products. So not everybody gets the same concentration. Again, it goes back to what you're trying to treat, severity, age of the patient. So you have to have an ability to be able to fluctuate those things based on the situation. Yeah.
So when clinics typically do PRP, then is that normal to change it based on the age or the requirement, or is it more of like a one size fits all?
Yeah. So most clinics. So we're lucky in the sense that we have kind of what we call our flexible lab platform, where we do a lot of manual processing. We still use centrifuge to kind of separate cells, but we do, different techniques to isolate and to adjust the concentration, as opposed to using something called a bedside or just an automated centrifuge, which is kind of this automated machine that the input is a certain volume of blood or bone marrow, whatever, and it pumps out a very specific volume at the end. And so most of these machines, you can only put in so much volume ahead of time, and it always gives you the same kind of output. And most of the machines that have been tested maybe can concentrate it just above baseline to maybe 5 to 7 times your base concentration. And they're not always kind of as accurate with, even in the same individual, you might get kind of variations in concentrations, even within the same person with the same volume. So it's really a one-size-fits-all approach that most clinics do. There's very few that have the space, the processing, the hoods, and the different manual processing that allows you the flexibility to create different products and different concentrations, all for one patient. You might need 10 different of these automated machines just to be able to concentrate 5 times or 10 times. Most of them can't even concentrate more than 7 based on the input and output, because a lot of them might only take 60 cc's of blood, and it always pumps out, say, 5 cc's at the end. So you can only get so much concentration from those cells. There's not a good way to fluctuate that, in a sense. And so, if these clinics that use that happen to have somebody that's a little bit older, have a little bit more severe problem, a little bit more severe arthritic change or tendon degeneration, then they may be underdosing those patients because of their inability to get, a certain level of concentration. And so, most clinics don't have the ability to do that, and it's more just a one-size-fits-all kind of approach and not necessarily customized to all those different characteristics that we talked about.
And it's really interesting that you have the ability to have that flexibility and dose those based on what you find.
Right.
And so what is it that, like, when you are evaluating someone, you have a little bit more advantage because you have other tools, right, that you're allowing the kind of actually, if you want to go through the process too, I'm kind of getting ahead of myself of how you're able to identify through ultrasound and
right.
use that and be able to specialize and individualize that laboratory response, if you want to go into that a little bit more.
Yeah, I think so. A lot of it gets in the beginning. It gets down to kind of the evaluation process and you have to understand what you're trying to treat in order to be able to create a plan and decide if what we do is going to be beneficial. So luckily, Regenexx as a whole has been around since 2005, right? So long time. We've always had kind of a research and development team to be able to kind of come up with the techniques that we have, which we have many, many patents for laboratory processing as an organization. And then not only that, we've always tracked patients as far as registry to assess outcomes, look at these different characteristics of patients that are maybe getting better, not getting better, complication rates, these kind of things. So that helps. So we kind of use that kind of in the background of tracking patients over the last, so many years. I think we're tracking about 35,000 patients in our registry now, following them actively over time. So that helps. And then the next component, knowing that we have that to kind of pull data from, is just the evaluation, right? So people come in, we have to understand what the problem is, right? So their shoulder, their neck, back, or a combination. And then we do need imaging, right? So we have to look at either MRIs, X-rays, ultrasound. For extremity-based stuff, we look at ultrasound to assess the tissue. So that allows you to see the severity. What's the problem, right? Is it some arthritic change? Is it a tendon issue, a ligament issue? Is it all the above? And then how much tissue is left? What location is it? Because certain areas respond differently. So like hips have their own characteristics as in regards to success and outcome, and certain things respond better than others compared to knees, which might have in general an overall higher success rate than hips. So there's different things you got to look at. So we use imaging to look at the structure. Ultrasound complements the MRIs to look at maybe movement. It's more dynamic, where an MRI is just very static. You're just laying there, right? And so it doesn't help necessarily movement of the neck or the spine, but like extremity-based stuff you can see. Mm-hmm. And so that allows you to see any instability in the joint, soft tissue issues, look at the structure. And then based on that, you're going to decide, well, you have a mild issue, a moderate, severe, you have bone on bone, you have a 2 millimeter tear versus a 1 centimeter tear. And then that's going to kind of push you down a path, right? So more mild to moderate, inflamed tissues. A lot of times we're thinking more PRP in that sense. And then we're going to look at, is it soft tissue or is it joint? Is it bone or disc? And that's going to help you fluctuate what concentration you might need, along with, or is it a 20-year-old or is it an 80-year-old? And so that's going to help you decide on what types of concentration you might need as well. Or do they need stem cells? And then, again, how bad is the tissue? What all needs to be treated? Does one thing need some stem cells, but something else could do well with PRP or something? Mm-hmm. Do they have an irritated nerve on top of their knee pain that's maybe contributing to their knee pain or something? We do treat spine and nerve irritation in the spine, and we inject something called platelet lysate, which is essentially taking platelets and breaking open platelets to extract only the growth factors. And so that seems to be better in the nerve space. And so that's another thing that we can do at the same time. So all those different, you're treating a soft tissue, a joint, and a nerve, you're going to have maybe 3 different products that you're processing for in the lab, so that at the time of the procedure, which is the same day, you can use these in the different areas that need to be treated. So the evaluation is important. The processing is important to be able to, provide the right type of concentration and product to the right area. And then obviously the delivery of that's important too, right? So are you using image guidance? You obviously have to know what you're going after, which is where the imaging comes into play. And then you have to use imaging to get it there. So whether that's X-ray or ultrasound guided procedures, to make sure you're putting it in to the tear of the tendon or into the joint or into the disc or into the nerve space, as far as safety goes, but also just to make sure that you're treating the problem. Mm-hmm. If you're not getting it there, then the chance for it of helping is lower, right? So just to maximize potential for outcome and safety as well.
So after the process, I mean, sometimes people take several visits, I would assume.
Some people do.
Mm-hmm.
Yeah, like in regards to procedures or just follow-up?
Well, I guess either.
Yeah, so when we don't tend to just kind of schedule a series of injections. We tend to do a treatment, whatever that is, and then we have regular follow-up, right? So usually every 4 to 6 weeks after a procedure, we'll want to see them back to assess how are they doing, what's their response to the procedure. You want to know if they're getting better, is it, doing what we hope for, are we seeing improvements in pain and function, are we seeing structural changes, and then along with that, some people will need obviously physical therapy, some people need bracing, some people need some modified activity for a period of time, depending on the problem and what you treated. But yeah, we tend to track people every 4 to 6 weeks in the clinic, and then based on those follow-ups and how well they're doing, some people may need another treatment or something. So it's kind of more based off their outcome. And if there's still residual symptoms, and some people will need more than one over time. So it depends on the problem, obviously, how much they use their body, is there, underlying mechanical issues that aren't being addressed, that are continuing to overload these areas. So they have alignment issues that maybe can't be fixed, like scoliosis or leg length discrepancy, or something that is putting extra stress on somewhere. So there's some people will need more than one treatment over time, depending on, a whole host of factors.
And then after they get the procedure done, is there a certain amount of time they're supposed to wait before physical activity, or if they are going to a PT, like can they go the next day, or is there, once again, depending on the individual kind of thing?
Depends. Yeah, most people 2 to 3 days will tell them to just take it easy. We want them to move, but you might not be doing as much. You want to be able to modify if you're sore, because some people do get sore. We just did injections. Those injections are creating a little acute inflammatory response in regards to trying to activate a healing kind of response. So people do get a little swelling and soreness. Usually about 48 hours is kind of that window where they take it easy. After that, most people can get back into physical therapy and start kind of increasing their activity. Usually for 2 weeks, we say keep it low impact for the most part. If it's like lower extremity stuff or upper extremity stuff, you might just limit how much lifting they're doing. And then after 2 weeks, again, this is kind of the generic kind of plan. Everybody might have a different plan if it's more severe problem. And then after that, you're just slowly, incrementally getting back to your normal base, right? And that's kind of guided based off how you feel, right? Obviously, if you have like a big tear that we're hoping that we can get some improvement in, you might be more restricted. Like you might be put in a brace or a sling. We might not want you to lift for 4 to 6 weeks on that area. So some can be more restrictive. But yeah, people can get usually back into physical therapy early, even though it might be modified compared to what they were doing. So instead, if they were doing a little more higher level therapy or sport specific stuff with lifting and other things, they might need to work more on like flexibility and, postural type things and maybe some modalities or something initially just to work on, kind of not overload the area as much and then get back into it. But most people can get back in pretty quickly.
What does it feel like when you go through the injection?
So you're still getting poked with a needle. Yeah. So there's that part to it. Most people, to be honest, are most nervous. So when we get the bone marrow, you have to do a bone marrow aspiration to do that. So you're using a needle, and you have to poke into the bone, and we get it from the back of the pelvis. And so you have to use anesthetic, so you numb. Sometimes we'll use a little IV twilight sedation if people are really nervous. But that's what people get the most nervous about, right? So, which is completely understandable. But tolerance to it is pretty good. So, 90% of people rate that process like a 2 out of 10 on the pain scale. There's always some people that are a little bit more and some people that don't really feel much. So
that's their favorite part.
yeah. Not very many, but
yeah.
But yeah, some people are like, oh, that's it? Yeah, no big deal. That's the majority of people. But there's discomfort. I mean, you are doing things to the body. You are using needles. You're poking into the body. So there's some discomfort, but it's well tolerated. It's very safe. There's lots of studies that we've done in regards to looking at complications. we have a paper of 2,300 patients looking at complications from like a bone marrow and stem cell type injection process. There's others out there. There's lots of data on bone marrow aspirations related to cancer, right? So that's where like bone marrow biopsies and things. So there's a lot of data on the safety of it. So it's a very safe procedure, but people get very nervous about it. But if you numb and you use, enough of the sedation, people do really well. As far as injections into the shoulder, knee, you're still getting poked. We use cold spray. You're still using a little local anesthetic, which can be helpful. You got to be careful of what type of anesthetic, because some are more toxic than others as far as to cells and tissue. So that's important. But we do use a little local anesthesia. You can do nerve blocks and things if you need to make it more comfortable. But in general, it's very well tolerated. People, feel a little pinch, a little sting when you start to numb the tissue. Obviously, some things are more uncomfortable than others. Like a disc injection is maybe more uncomfortable. A bone injection is more uncomfortable. You might need more sedation. But the normal type joint injections or those things are pretty easy. Very well tolerated. People get up and walk out of the clinic, like that kind of stuff. So it's just kind of same day. Come in, it's an injection. Again, some might feel pressure, some might feel a little sting. Finger joints and hands are a little more sensitive than other things. But again, there's ways to kind of make it more comfortable through medications or nerve blocks or just anesthetics and stuff. So very well tolerated, very, very easy for most people to kind of get through. And most people that have had maybe injections at other places where they didn't use image guidance, they're just doing like a blind knee injection, injecting cortisone or a gel injection or something. We hear people be like, it was the worst experience, it hurt so bad. Where technically joint injections shouldn't really be painful. If you're getting into the empty space of the joint and you're not injecting into soft tissue or the fat pad or synovial tissue, then it shouldn't, once you get into the joint, shouldn't really be that painful if you're doing a joint injection. But some people like, oh my God, cortisone injections hurt so bad. Well, really it shouldn't if you're like, if you know that you're right in the joint space. But a lot of places just kind of feel on the joint and like stick the needle in and kind of hope that it's in that area,
That's a knee.
Yeah. It's like, oh, okay, I got it. I injected by the knee. Did it go into the joint? No idea. But some people still do blind injections, even though we have ultrasound. There's studies that compare blind injections from seasoned orthopedics that don't get into the joint all the time in a blind injection. But if you're using ultrasound, you can see that you're there, right? So even people that stick stuff in the knee all the time still miss if they're not using image guidance. So that's important, and I think that also helps with the tolerance and stuff. That you're not kind of messing around trying to find it by poking the needle back and forth. You're just going right into it more efficiently. So that helps too, I think.
It's funny. It's like some of our patients, we do dry needling on them.
Oh yeah.
And then the more it stings, like if they're a CrossFitter, for instance, like the more it stings, they're like, oh, I think it's working.
Yeah,
like
yeah.
It definitely, like if it hurts a little bit more, then they feel like it's a better treatment outcome.
Yeah. Well, I've had patients like that too that came and we did a spine injection. Always using X-ray. We're like seeing all the flow and stuff. And he was like, yeah, the first time I got an injection, it like hurt really, really bad, but then I got better. So... And then when we did it, it didn't really hurt that bad. So
it's like missed.
Yeah, he was like emailing me all the time, like, "Are you sure we got it? Didn't really hurt." So like, "Are you sure that it's gonna help me? Are you sure?" And I'm like, we don't really want it to hurt. Like when you're injecting, like doing like an epidural, if you're kind of right in the space where it to flow really nice, it shouldn't be that painful. You might feel some pressures or sensations, but it shouldn't be like this extremely painful situation. But he was like wanting that because he thought that correlated with his outcome, so. But yeah, so people do like that obviously there's a mental side to it and placebo side to some things, right? Just sticking needles. I mean, into people, sometimes that's all that's needed. There's an intervention done, and that helps them a lot. But so yeah, but yeah, dry needling for some people can be painful depending on where you get and how irritated the tissue is.
What would you say would be the ideal patient for you?
I think there's actually a wide spectrum, and as far as the patients that we see, I think somebody that's relatively active that wants to be a little bit active. The big thing is we see people of all ages, and certain types of structures are affected by age, where like hip joints, as we get a little older, don't do as well as other joints. But knees, when we've checked outcome from 30 to 90-year-olds, you don't see any drop-off in success in regards to the average rate. So in that sense, there's a lot of people that could benefit from what we do. Even people post-surgical that are having some continued pain, I think that not necessarily they're the ideal patient, because obviously they just had structure changed and they're fused or replaced, but post-surgical pain can still be there for other things that might be able to be treated, like soft tissue type issues after a knee replacement. You can see tendon issues, ligament issues. But in general, if people have, want to be a little bit active, are relatively healthy, the healthier you are, the better chance you have for healing, as opposed to somebody that has metabolic syndrome, significant, body inflammation. A lot of times those patients are going to have more flares after the procedure because they're already inflamed, and then we're trying to do a procedure that creates localized inflammation. And a lot of times these people are dependent on anti-inflammatories like ibuprofen and Aleve. And we want people to get off those medications before. So in regards to preparation, people have to get off some of these anti-inflammatory medications. And so those people can get big flares. So people that might have to prepare by changing their diet, reducing their total body inflammation by eating more natural foods, getting away from processed sugary foods, doing some type of aerobic activity ahead of time, transitioning to more natural-based supplements like fish oils and turmeric and glucosamine, stuff that has some natural anti-inflammatory properties ahead of time, and that can help going into it. So people that I think at baseline have been a little bit active, don't have significant total body inflammation, and then outside that, it's just more structure dependent, so really bad bone on bone where there's just no tissue and there's alignment issues, those are really hard to change. So people that have more focal problems, even if it's a little more severe, but it's more focal as opposed to, the whole joint being affected, then the outcomes are different in those situations. I wouldn't say there's one age that's better than others, but younger patients have a more robust healing response. But we've had great success with people older. Again, it's just adjusting the concentration. So you can see similar successes with different age groups. So that shouldn't really be a barrier to people coming in. So it's too hard to pick one ideal patient because you can adjust things to try to get the different situations and maximize each type of patient's success based on concentration, dosing, repeat injections, things like that. So.
And what's something you commonly see in your practice that you wish more people knew?
I think the biggest thing, a couple things, is that people should try to avoid cortisone injections at all costs, I think, even though they're kind of standard and for some reason they're still covered by insurance, even though there's growing data that they're so toxic to your body. There's many studies looking at how toxic they are to your cartilage, your tendon. There's studies that look at how fast it leads to knee replacements in patients that get cortisone versus people that don't. But people, doctors alike and patients, I don't think people aren't educated on those adverse reactions from these, especially like with recurrent exposure. But they do them because they're simple. They help for a period of time, so people feel good. But there's a long-term detriment to those things in regards to your tissue health, your bone health. If you have diabetes, they're horrible for you because your blood sugars spike. Some people are very sensitive in regards to weight gain on them and stuff. So, but I don't think people truly understand how bad they really are. And I feel like they shouldn't really be part of the traditional kind of first line treatment for joint issues or inflammatory orthopedic conditions. I think PRP should take over the role of cortisone in most circumstances. Not all, of course. And there's comparative studies looking at least for knee arthritis and some other conditions, PRP versus cortisone, with PRP being more successful, and SI joints and knee arthritis, things like that, lateral epicondylitis, those kind of things. So there's data to show that PRP maybe should move ahead of that. But people just got my cortisone every 3 months for the last 3 years, and you can see how much their tissue has been affected over that time. And then the other thing is just understanding the exposure to potential risk from surgery. I feel like some people, I get the impression that they just think, surgery is the fix. It's going to cure my problem, but not realizing what you're exposing yourself to in regards to complication rates, revision rates, continued pain rates after surgeries, right? Knee replacements, spine surgeries, there's large complication rates, like serious advent rates, and knee replacements can be 15% or more, right? Infection rates can be 1% of the patient. So if you're looking at that compared to, say, an injection type treatment, like your potential for something going wrong, and those things tend to be a lot more severe if they do go wrong. So having the mindset of what's the least invasive thing I can do that could potentially help me prior to exposing myself to all the things that can go wrong with a more invasive procedure, and having kind of a different mindset and kind of how to address their problem, and not necessarily thinking that surgery is like the fix, because it's often not the case, and we see a lot of people that still have pain after surgery. And success from surgery doesn't mean 100% relief of your symptoms. It just means that maybe one problem's gone or reduced, but there might be other things that come from cutting the tissue, removing it, those kind of things. So.
And what's something that you've been working on, whether it's professionally, personally, physically, or mentally, that you're excited about?
I think the big thing here is just trying to expand kind of different types of things we're doing here in the clinic. Here we're trying to grow kind of our corporate program where companies are starting to cover Regenexx, and so we're trying to really put a lot of energy into that, just to allow more access for people to have this as part of their decision-making process, which I think is really good, that some employers are finding that giving patients some freedom in what they choose in regards to how they're going to treat their body. So that's a thing that we've been working on a lot and trying to expand that. And the other thing is I have a 7-month-old child, so just kind of being involved with her and watching her grow. So that's been such a pleasure and a learning process for sure these past 7 months. So that's obviously probably trumps everything else, but so that I've been excited about that too. And then seeing her grow and the holidays and seeing family and stuff and letting them meet her.
What's the biggest thing you've learned as a dad?
Well, I think the biggest thing is just one, they grow so fast. So you see so much change in such a small period of time. Patients, obviously, you know, there's just, they have no idea what you're telling them to do or if they're being fussy, and like you have to kind of take a step back and be like, okay, like they're just responding and reacting. And then just the fact that there's stress that comes with it. Like your mind sometimes, you know, you want to just protect them so much. So like it's so, you know, realizing that you think about all the bad things that could happen and how you want to protect them. So there's like so much of that goes in my mind. But then just like the hope for the future too, just like, you know, you just want the best for them in the long run. So, so all of that, it's definitely a learning process, but it's fun. Yeah.
And what do you want to leave the listeners with?
I think just to remember that there's different options for treating orthopedic problems, to ask questions, whether it's you're talking to your orthopedic doc and they're talking about cortisone injections or other types of medications or surgery, to ask questions. Ask about successes, failures, what are complication rates, what are things I need to think about in the future, and then just having an open mind about different alternative type things that could be helpful, and not jumping into surgery without really doing your homework on what else could potentially help.
And how can people find you?
So on our website, RegenexXLasVegas.com, that's probably a good step. There's a lot of information there on what we do, outcome data, and then just here at the clinic, they can call us just directly as well. So the number here is 702-722-6030. Some of the contact information on our website directs people to our education center, basically just help facilitate education, getting imaging and other information out to them if they have more questions. Those are probably the best ways.
We'll put your info in the notes too of the show so people can see it.
Yeah.
Well, we really appreciate your time today.
Yeah, thank you guys.
One last question.
Yeah.
Favorite food?
Favorite food. I actually like pizza. That's fun. I could eat that all the time.
Excellent.
All right.
Thanks
Thank
again.
you, Dr. Goodwin.
Yeah, of course.
We'd like to thank you for listening to La Vita Las Vegas podcast. We hope you enjoyed the time with our guests as much as we did. It would help us out so much if you could share, subscribe, or review our podcast, or any combination of the three. Thanks again, and remember to take care of yourself.